So hello and welcome students, and in today's segment we will be discussing a question that was asked in one of your exams about acute urinary retention. So the questions language was urinary retention in first trimester of pregnancy, the management of urinary retention in first trimester of pregnancy. But when they talk about such a question, it was a 5 marks question, and when they ask about the management, even for me it was difficult to categorize and finally find out the correct management for you. So I have made an algorithm which of course I'm going to share, but I just wanted you, whenever such a question comes, what all things should go into your minds that it's easy for you yourself to answer the question, because there are many times such googly questions will be asked to you. One of the questions that was also asked in your exams was regarding the clinical significance of internal iliac artery, the clinical significance of internal iliac artery. Now, to do justice with this kind of question, it is not easy. First of all, it was the course of the internal iliac artery, which is all right, 5 marks for that, and the clinical significance of internal iliac artery in obstetrics and gynecology. So in this kind of question, all the indications there are of the internal iliac artery should be enumerated. Description is fine, but at least enumeration has to be there, otherwise you'll lose marks. So anyways, that also I've included in one of my segments, and probably let's see if I can post it later on. But for now, let's discuss a question like acute urinary retention, especially in the first trimester. So what you should think in such a case when such a question is asked to you. Now you think about it, that if urine is getting somebody is not able to pass the urine, what all factors are responsible in the first trimester? Just think about it. Second trimester is still I'll get to it and then I'll tell you how in second trimester it becomes still understandable. But in first trimester the uterus is so small. So how can it impinge upon the bladder so much, even if it's retroverted, that it can cause acute urinary retention? And mind you, this is a emergency situation. So I have designed an algorithm, and exactly according to the flowchart I will go here in this class. So this is a emergency. So if a patient comes to you with acute urinary retention, the first thing of course will be, because it's an emergency, you will start to drain the bladder. So as to relieve her of her obstruction. And then you will go first and foremost regarding the history. When did it start? Was it earlier little bit and then it increased? Did you experience urinary retention before as well? Was there any pelvic mass associated before? Had you been through any surgery? Were you already a diagnosed case of endometriosis, endometrioma, pelvic adhesions already known? Was there a myoma already known? And urinary infection, did it happen? Were you having some symptoms of urinary infection? So history will be there. Obviously, whenever you start with management, you have to start with diagnosis and then treatment. So when you're starting with diagnosis, mention the history always, mention physical examination always, mention imaging almost always, because almost all our cases are dependent on imaging. So then you come to physical examination. What will you look forward into physical examination? Once you've relieved her of her pressure, the bladder is draining properly, then you get to examine the pelvic structures. Can you feel something in the posterior fornix? Can you feel the myoma anteriorly? Do you feel that the cervix is too much? You can't even feel it. Somewhere your hand is in the posterior fornix only, and the fundus is felt right at the through and through. There's no posterior fornix as such. So there is completely a blunting of the posterior fornix, and there is no fundus which you can feel above. So you know that it's a completely retroverted uterus, and that cervix is impinging on the bladder neck, and the fundus is on the sacral promontory somewhere. So it's lying like this flat, and it's pushing the opening of the urethra anterior or urinary bladder anteriorly, and resting on the sacral promontory posteriorly, and growing that ways. So basically the examiner in this case wants to hear this. They want to hear about the acute retroversion of uterus and how to relieve it. So after of course an elaborate history and elaborate per vaginal, per rectal examination, next step is to go for imaging to diagnose, to finally confirm your diagnosis through imaging, ultrasound, even MRI if it is needed. Now, at the same time, you've sent urine for culture and urine for routine. All right. Now, by the time, suppose if the result comes and it was, maybe acute infection, and it felt like, a lot of swelling and edema of the, urinary bladder and the urethra is causing it. So then you go for antibiotics. That's that management. Suppose in the imaging it comes out to be an incarcerated myoma, or severe pelvic adhesions which are causing it, endometriosis which is causing it, then maybe surgical method is the only choice you have. So what will you do if there is an acutely retroverted uterus? So of course, vaginal manipulation along with rectal manipulation might bring back the fundus in front. Otherwise, the knee, the head knee position, in which you ask the patient to, kind of prostrate like this, bend over, and that might lead to, kind of getting the fundus back anteriorly, and then if you push it by your hand as well. Apart from that, you have the Trendelenburg position, but in which you'll have to steep Trendelenburg position, but you'll have to cup it in such a way that it can come out, putting the hand from abdomen and pushing the hand from below. Then you have colon assisted reposition. So that is one advanced step of the same thing. And if all these maneuvers they fail, then unfortunately you have to go for a surgical maneuvering of the fundus to put it back into position. So very, very rare case of acute retroversion of uterus can be put back. I'll just read it. You have vaginal maneuvers, you have rectal maneuvers, you have knee chest position. Like I said, you have Trendelenburg, steep Trendelenburg position in which you try to put it back. And then you have the colon assisted reposition of the fundus back into place. And if all these methods fail, you have surgical method as the choicest method finally, which unfortunately you don't want to do it, but that's the last resort. In the meanwhile, of course, you're giving her antibiotics if you're trying to relieve the pressure through draining the urinary bladder continuously and assessing the other related factors. So I have made this flowchart, and you can see it right here, and this and many more answers I'm making continuously so as to make that answer bank and bring it to you as early as possible. Next up will be the clinical significance of internal artery ligation. So stay tuned, keep watching and keep learning.